Welcome to Cardiovascular Assessment. This is a review and summary of basic cardiovascular assessment highlights. You can use it to test your knowledge and understanding. Our standard disclaimer is listed in the small print there on the left. Basically says that we do the best we can to provide accurate and current information, but this video is not designed to replace your professor's information, but instead to supplement. So, when I talk about assessment from a basic assessment chapter in your nursing textbooks, I look at the highlights and I look at the highlights of things that you don't necessarily think of or that are very important to that body system. So that's why it says highlights. I'm not going to cover every single assessment thing that could be there because that's kind of boring to talk about and you know those. I'm just going to highlight items. So remember, subjective are things that the patient reports to you, not things that you observe yourself. So first, let's start with risk factors that are really important in the cardiovascular system. And again, these are a lot of the ones that you do know, so we're not going to spend much time on them. So increased serum lipids, and of course that's lab values, hypertension, smoking. Remember when we talk about smoking, we talk about pack years, which is the number of packs they smoked per day times the number of years they smoked. That's often asked on tests, something people like to ask for some reason. Sedentary lifestyle, our gentleman there on the far right. He also represents obesity, which of course we know is a very big problem. Unfortunately, it's becoming a big problem in children, and we're now starting to see cardiovascular disease in children, which is quite sad. Stress, our man there on the top. Of course, that's you too in nursing school, and unfortunately, that risk factor will affect you. So you've got to learn how to deal with your stress while you're in nursing school so that you don't create problems later in your life. And then diabetes. So my question for you is, are all of these risk factors modifiable? So remember that modifiable means things that people can do something about. Non-modifiable, they can't do anything about. So just a test-taking tip, when you're doing teaching, don't pick something that's non-modifiable to teach about because there's no point at the beginning of teaching to teach people about things they can't change, like their genetics or their race, their age, those kind of things they can do nothing about. We want to do things that are modifiable. So the question again, are all of these risk factors modifiable? The answer is yes. Of course, that doesn't mean it's easy, and it doesn't mean that everything's going to work. We can't always get the lipids down. We can't always get the blood pressure down. But all of these things are modifiable, even diabetes. And a lot of people think that's not because it's a disease and they can't help that they got it. But it is modifiable in that they can control how high their sugars are and try to keep those in a better range. Excuse me. Continuing on subjective assessment. Allergies to iodine dye. So why is that important with cardiac? It's because we have a lot of cardiac tests that require iodine dye, cardiac cath, other diagnostic tests. So that's important. Before I continue on this, what's really important with the subjective assessment is differentiating symptoms that reflect a cardiovascular problem from problems of other body systems, respiratory, GI, whatever. And also remember that many illnesses can affect the cardiovascular system not just directly, but also indirectly, like sleep apnea that we'll talk about in a second. Okay, familial disorders. So these are things that suggest cardiac problems. A heart disease before the age of 55. If that runs in families, then a younger person is at higher risk and they need to be monitored more closely. History of intermittent claudication. We'll talk about that in a minute, but that term you definitely need to know. It's tested on a lot. Intermittent claudication is where they report that every time they exercise, even light, walking, whatever, any kind of exercise, they have pain in their legs. And the defining symptom is it's intermittent, but also that it's relieved by rest. So if they sit down and rest for a little bit, it'll go away. They can walk a little bit more and then it comes back. So intermittent claudication. Varicose veins, because the valves are insufficient. Other disorders that can affect cardiovascular, like asthma, kidney disease, liver disease, obesity. If any of those run in the family, important to find out. Constipation. Now, why in the world would we have constipation in a cardiovascular assessment? And it is very important. If you work on a cardiovascular floor, it's always talked about when was their last bowel movement. They're always on medications for it. Why? It's because constipation leads to straining or Valsalva. Make sure you know that term too, because we'll talk about it a lot in cardiovascular. Valsalva is that bearing down that we all do when we have a bowel movement. When we do that, it stimulates the vagus nerve and it can drop your heart rate down low. So that can be a big problem with somebody with a cardiovascular disease. So a history of constipation along with cardiovascular disease needs to be taken very seriously and treated. Exercise intolerance. Do they report that when they exercise they get chest pain or shortness of breath or that intermittent claudication, that cramping in the lower legs? PND, make sure you know what that is, paroxysmal nocturnal dyspnea. This is attacks of shortness of breath or coughing at night that'll wake them from their sleep. It's very frightening, and it happens because of fluid exchange that doesn't occur very well when they lay down. Orthopnea. Again, you need to know what all these terms are, not just the words, but what it means and what causes it. So orthopnea is the inability to sleep lying flat because they can't breathe. So every time they lay flat, they can't catch their breath, so they have to sleep upright in a chair or with pillows behind them, and we tend to chart that as how many pillows they need. And then sleep apnea, our picture there up in the right hand corner. Sleep apnea greatly increases the risk of dysrhythmias, and it can lead to cardiovascular problems. So if they have that, and as we know, lots of people have it now, it's important to know. And then sexual problems. This could be erectile dysfunction. A lot of times erectile dysfunction is what brings people to the doctor, men to the doctor, and they discover there's a cardiovascular disease happening. So ED is really important. Also, the drugs they take for ED is really important. So there's a picture of Viagra there. Viagra, you have to know if they take that before you give them nitroglycerin, because you can drop their blood pressure so low that they could die. So it's really important that we ask that question. That's always tested on, is do they take Viagra? And when you're really asking that question in the real world, you need to be very clear. It's very important that I know, have you taken Viagra today? Because I'm going to give you this medicine and it's going to drop your blood pressure completely down if you have taken this. So I need to know. So really important. Another one is the other picture I have there, birth control pills, hormone replacement therapy. We know that these increase the risk of clots, blood clots, so it can lead to cardiovascular problems. All right, on to objective assessment. So those things we can see, touch, hear, feel. Blood pressure. Of course, blood pressure is very important. We need a baseline. So the first time you take a blood pressure, you should take a reading in both arms and then use the arm with the highest blood pressure for future readings so that we have a good baseline. Can we take blood pressures in the legs? Yes. Can we take them in the wrist? Yes. The important thing is that we document where we took it and we compare apples to apples, because blood pressure readings are different where you take them. So like in the legs, they're higher, 10 millimeters of mercury higher than in the arms. So it's really important that we document where we took the blood pressure. Orthostatic blood pressures. Make sure you remember that term and the order. So it's supine, sitting with their legs dangling, and standing. We expect that the systolic is going to decrease less than 20, and the heart rate should not increase more than 20 when you go from supine to standing. So even though, honestly, they don't really believe the orthostatics tell us a whole lot, but people continue to order them and we continue to test on them. So you do need to know about orthostatics. All right, the peripheral vascular system. So inspection, remember inspection is looking at things. So things we can look for. Hair. If they don't grow hair, I don't know about you, that sounds fantastic to me. But if they don't grow hair, it's important that we know that. So on a man or a woman, we should ask them, does hair grow on your legs? Because if it doesn't, that oftentimes shows that we're not getting good blood flow to the legs. Edema, you know about edema, you know how to check for edema. Dependent rubor, that picture down in the lower left corner is dependent rubor, where one may be a different color, one extremity may be a different color than the other, and when it's hanging down, it's got this dark color. Nail bed clubbing, remember talking about that with respiratory, where the nail beds are not even, and that comes from chronic low blood oxygen. Varicosity, so I show you a picture of varicose veins there where the veins just look real lumpy and bumpy, and so that's where the valves are insufficient in the veins. So a history of that is important to pay attention to. And you can get varicosities other places besides the legs. Hemorrhoids are actually varicose veins of the rectum, so you can get them other places. Stasis ulcers, that top picture, that dry ulcer on the legs, dermatitis, their skin is shiny and dry and oftentimes broken down, doesn't heal well. Important to know if they've had those and how long they've had them. JVD, jugular venous distension. So you can see on that gentleman. Now, the first question is, how do we check that? Remember, you've got to put the head of bed up about 30 to 45 degrees. He looks like he's probably a lot higher than that, because it's really common when they're laying down to see what would look like JVD. So when they're laying down, you can't say someone has JVD. You've got to put them up some. Also, with that Valsalva maneuver, with that bearing down, you can't say someone has JVD when they're doing that. You have to actually have them at that 30 to 45 degrees. What does JVD tell us? It usually tells us about right-sided heart failure. The blood is backing up back into the body, and oftentimes with JVD they'll have edema to their extremities too. Palpation, so feeling. Remember, we always want to compare pulses simultaneously for symmetry. Now, what is the one pulse in the body that we do not compare simultaneously? We press on it at the same time. Carotids. Yep, you'll pass out. I guess theoretically you could die, but you never press both carotids at the same time. But everything else, you have to actually feel them at the same time or pretty close to the same time to truly compare to see if they are equal on both sides. Narrowed or bulging vessels, how will they feel? Oftentimes they'll vibrate or feel like the term they call thrill, a little buzzing kind of feel under your fingers if they have narrowed or bulging vessels. How about capillary refill? What does that tell us? It tells us about arterial flow to the extremities. So now cap refill has a lot of times it doesn't work real well. If your fingers are real cold, you don't have a lot of blood in your body, lots of times it won't work, but we still should know about it. And then auscultation in terms of the peripheral vascular system. Bruise, when do we hear bruise, that whooshing sound, and where? So we listen over the carotids, the abdominal aorta, the femoral arteries, and those bruises are heard where there's narrowed or bulging arteries. Continuing on with objective assessment, the thorax. So inspection and palpation here. So make sure that we know all of the thorax landmarks. These are oftentimes asked in questions, and so somehow you have to know them. I think the best way to know them is to point them out on your own body. So instead of just looking at the picture, find them on your body, and then when you're taking a test and you see those words written down, think about where that is. If you have to, point to it on your body so that you can find it better. So this doesn't have all the pictures on them, but it does have some. So the angle of Louis, that's that raised notch right at the second rib. It kind of starts everything. It's that sternal angle as you see on this picture. Then the oscillatory areas, and I covered this in the A&P review, but I'll cover it again here. Remember, it's different than the order of the blood flow where you listen. And you have to, again, know the locations by word, but also on the body. So the aortic valve, second intercostal space to the right. The pulmonic valve, second intercostal space to the left. The third intercostal space on the left is Erb's point. On the left is also called, well, really on either side is also called the sternal border, left sternal border or right sternal border. So moving on down, the fourth intercostal space on the left is the tricuspid area. You will sometimes hear the fifth listed too. So the fifth at the left sternal border or the fourth would be tricuspid area. The mitral valve is also the PMI, point of maximal impulse, and is the fifth intercostal space, the mid-clavicular line. And see that the mid-clavicular line is halfway through that side, through either side of the chest. Remember, the mid-axillary line is halfway, is underneath the arms. So make sure you read carefully when you're reading questions on exams. Do we feel pulsations at any of these areas on the chest? Typically no, except at the PMI, at that mitral valve area, unless the patient is very thin. So we're really not concerned if we feel pulsations if the patient is very, very thin. If, however, they don't say the patient is thin and there's pulsations and maybe there's pain, those things are bad. So if we feel a PMI at the sixth intercostal space, maybe to the left of the midclavicular line, what would we think is happening? Is that normal for the patient, or is that a sign of a problem? And so that's a sign that the heart is enlarged because the PMI is lower than it's supposed to be. Okay, make sure you know where the epigastric area, it's basically where the arrow is pointing to the xiphoid process, it's directly below that. So that epigastric area, again, we may feel or see a pulsation of the abdominal aorta there in a thin person. Again, if it's a thin person, that is normal and not unexpected. If, though, there's pain, there's high blood pressure, it's not a thin person, we hear a bruit, then that is probably abnormal. It could be something like an aneurysm that's bad. All right, heaves. So the picture at the top is showing feeling for heaves, where you feel or you can sometimes see lifts of the chest wall. And usually this is related to left ventricular hypertrophy, where that left ventricle is more enlarged than it should be. And again, with that, we would also expect to see that PMI, the apical pulse, to be displaced. And then lastly is percussion. We typically don't do percussion as nurses. I know they teach you that, but you really won't ever see a nurse doing that. You will see cardiologists doing it all the time. But percussion is done so we can feel those borders of the heart, so they can, again, kind of use that as a judge to feel how far they're extending beyond where they're supposed to. Continuing objective assessment, we'll talk more about the thorax, the auscultation of that. So diaphragm versus the bell. So which do we listen with most of the time with our stethoscope? That'd be the diaphragm. It hears high sounds, and S1, S2, or normal sounds are typically high-pitched sounds. The bell hears low sounds. So the way I remember that is the L's in bell are low sounds, and those are typically abnormal sounds. Again, they all have L's in them. That's how I remember it. So the S3 and S4. Now remember that if you press very hard with your bell becomes a diaphragm. You have to hold the bell very loosely. Again, another L. The best way to remember all of those. So S1 is that closure of the tricuspid and the mitral valves, the lub of the lub-dub, the beginning of systole. S2, closure of aortic and pulmonic valves, the dub, and that's the end of systole, the beginning of diastole. Really important that you think about these positions, and I would tell you, do this while I'm talking about it. Lean forward while they're sitting up. So when they do that, you can better hear the aortic and pulmonic. Remember, those are up on the second intercostal space, left and right side. Leaning forward, sitting, brings that a little closer to the chest. We can hear them better. To better hear the mitral area, and I'm telling you, this is always tested on, the patient should lie on their left side. Again, do that. Lie on your left side so you remember this. That brings the heart closer to the chest wall, so we are more likely to hear the PMI and we can hear that mitral area a lot better. Questions are asked about this all the time, so you've got to know that. Pulse deficit. Pulse deficit is the picture that you see above. When you auscultate the apical pulse while you palpate the radial pulse, if these pulses are different, then you get two people in the room and you have one person count each one for a full minute. This is usually caused by a dysrhythmia, so important that if we recognize it, that we follow through. Splitting of the S2, another thing we talk about. This occurs during inspiration. It can be very normal. So it's best heard at the pulmonic area, so the second intercostal space, left side. It's abnormal if you hear it during expiration or if it's a fixed sound. So how can we tell if something is happening during inspiration or not? Yes, have them hold their breath while you listen for that split. And it has to be a slow heart rate, and you have to be really used to it to hear it. So you need to not feel like you have to know how to do that. You need to understand what it is, though, and how it is assessed. S3. This is a sound that's heard after S2. We call it a ventricular gallop, usually. Has the sound of Kentucky, that rhythm. It can be normal in young adults, so it's always important to know when this is normal and when it is not normal. But usually it's a sign of left ventricular failure or a mitral valve problem. So those ventricles are not filling well, they have a problem with compliance. S4. S4 is an atrial problem. It's heard again after that S2, after that S3, before the S1. And it falls with Mississippi, the term. So we've all heard that term. It doesn't make a whole lot of sense to me. I don't hear it, but on my website I do have links to some videos with these sounds so you can hear them. Again, S4 can be normal in older adults if they have no heart disease, which is not that common. But it's usually a sign of coronary artery disease, cardiomyopathy, something wrong with the ventricle, or aortic stenosis, a sign of several problems. Murmurs. I think everybody knows what a murmur is. Remember that it's caused by turbulent blood flow across diseased heart valves. And you'll learn about them more in detail when you talk about the heart valve chapters. And the other thing you need to know about them is they're graded by loudness. So out of 5. So 3 out of 5 or 2 out of 5. They grade them by loudness. Lastly, pericardial friction rubs. These are very high-pitched, scratchy sounds like sandpaper rubbing, usually heard at the apex when you're sitting or leaning forward. That positioning, usually related to pericarditis. So again, you'll talk about that when you talk about those disorders. Hopefully this was helpful to you, touched on some of the key points in assessment. Watch for more cardiovascular videos coming soon. Check out the website. I'm trying to create a game right now of matching so you can test that your knowledge of these symptoms. And then watch for our app coming soon. As always, we appreciate your feedback, so like or dislike our video, please write comments and subscribe to our YouTube channel so you'll be the first to see the new videos. Thanks for watching.